So good afternoon from Kenya, everyone. It's great to see you. My name is Erin, and I help run the program that we're now in the 4th week of, which is an introduction to palliative care for humanitarian healthcare workers. We're great to have and glad to have Dr. Anna with us today from Canada. She'll be facilitating this session, and Dr. Kathryn will be running our case presentation, and Dr. Esther from Kenya will be facilitating the lecture for today. So I'll hand it over to Dr. Anna. Just a quick reminder, please rename yourself on Zoom so we can track your attendance for the program today. And if you have any questions, you can put them in your chat. We would just like, because we're a large group, just to remain everyone on mute unless you've been called by the faculty members. So welcome, Anna. It's great to have you guys here today.
Great, thank you, Erin. Welcome, everyone. It's really great to see everyone back again, and I hope you've enjoyed the first few sessions that we've had so far. We have a great lineup today, and for this palliative care humanitarian echo. And our topic today is opioids and pain management. We're going to start with a presentation by Dr. Esther Nafula, and then we'll have a discussion, and then Dr. Kathryn Richardson will give us a case presentation. Afterwards, we'll go into small group breakout sessions to have discussions and answer some questions about the case and our session, and then we'll close the session at the end. And so really invite you to participate. Please use the chat box to ask any questions that you might have. Just a reminder to please put yourself on mute if possible, and feel free to have your camera on if you'd like. But if there's connection issues, then it's fine to have it off. But again, please use the chat box at any time. So without further ado, I'd like to introduce Dr. Esther Nafula, who's a palliative care consultant and specialist out of Kenya, and she's going to give us a presentation on pain management. So Dr. Nafula.
Good afternoon. I hope you can hear me well.
Yes, we can.
I would like to start. Yes, I would like to start sharing my screen now. So I'm going to give a presentation about opioids and pain management. And we'll be looking at the availability, local availability and accessibility of opioids in our East African setting. So by the end of the presentation, I hope that you can be able to explain the basic principles of pain assessment, pain management, and to be more familiar with the analgesics, including opioids. So I'll start by defining pain. Pain has been defined as an unpleasant sensory and emotional experience that is associated with potential or actual tissue damage, or it's described in terms of such damage. That is according to the International Association for the Study of Pain. Then it is also defined as what the patient says it is and occurs whenever the patient says it does. So what I would like us to note is that pain is a very subjective experience. So the first rule about pain management is to believe what the patient says, because the patient is the one experiencing the pain. We are not the ones experiencing the pain. Therefore, when someone says they're in pain, the first thing is to believe them and to believe what they tell us about their pain. So why we want to talk about managing pain is because untreated pain leads to a lot of anxiety and depression, increased suffering for our patients, and overall decreased quality of life. So when we do pain assessment generally, the important things to remember is we start with taking a history about the pain. Then we need to examine the patient at the site where they say they have pain, and then send them for relevant investigations. And in palliative care, the rule about investigations is to send for patients for investigations that are going to make a difference in our management. So if we suspect someone has liver metastases, we might want to do an ultrasound. If we suspect there's a pleural effusion, we might want to do a chest X-ray. So keep the investigation simple and simple enough to give you an answer to be able to treat the underlying problem. So there are 7 simple questions that we want to ask about pain. When we're talking about pain to our patients, we want to ask them what are they feeling? So what is the pain? So they describe for us the pain. Then where is it? What is the site? Where is the site of the pain? When does the pain happen? When did it start? So there's when it started, there's the timing and duration of the pain. There's the frequency of the pain and any pattern that the pain has. Then we have treatment. So treatment means any analgesics the patient has been exposed to, what their experience has been with the medication. Was it over the counter? Was it a prescription from hospital? How were they taking the medication? And what kind of side effects did they experience with the medication? Then again, we might want to figure out what is the cause of the pain. So any history about that pain, previous history of similar pain, or being on treatment for any medical conditions. Now, when we finish taking a history, about asking these 7 questions, the next thing is to use a pain rating score. So we have some tools that we use to assess pain. The first one is the numerical pain rating scale that is useful for children from the age of 9 and above, and adults and people who are literate. So we ask them to rate their pain on a scale of 0 to 10, 0 being no pain and 10 being the worst possible pain they've ever experienced. For children who are from 3 years to 9, and the ones who are illiterate or illiterate adults, we use the faces scale, Wong-Becker scale. These are the faces that we can see here. So again, we have a normal or smiling face, and we have a very sad face between 0 and 10. So again, 0, there is no pain. Up to 10 is the worst possible pain. Sometimes patients are not able, or we do not have these scales to use. So we might just want to use a super simple scale, which is the verbal rating scale, where there is mild, moderate, and severe pain. And we can simply ask the patient whether they have small pain, medium pain, or big pain. So it would be mild, moderate, or severe. Now, for some of our patients are not able to communicate, and some are very young, like neonates or children below 3 years, and they're not able to self-rate their pain. We use behavioral scales, and the common one is the FLAC scale, where we will look at their face, legs, activity, cry, and consolability. And the score for each of these parameters is between 0 and 2, giving us a maximum score of 0, a minimum score of 0 and a maximum score of 10. Again, 0 is no pain and 10 is severe pain. So we look at the facial expressions, we look at the activity of the child, we look at their legs, whether they're crying and can be consoled or not. Now, this assesses one aspect of pain. So physical pain. Now remember that pain is not just physical. Pain has the other components. Sorry, when we are going back to this slide about quality of life. So pain is more than just physical. When we deal with palliative care patients, we look at the concept of total pain. And total pain is just more than physical pain. We also look at the psychological aspects of pain, social, spiritual, and physical. So there is physical pain, then there is how it is affecting the mood of the patient, the activity, their social life, their finances, and their spirituality.
Sorry, Dr. Esther, I think you should advance. Yeah,
yes.
perfect.
Yeah. Are you able to see my slides?
Yeah, we just were off on a slide, I think, but I think you're okay now.
Okay, sorry. Now, when we look at the principles of managing pain, in palliative care, we want to keep it very simple. We manage patients by the clock. So by the clock means when we are prescribing medication, it should be given at the exact number of hours. Instead of telling a patient to take your morphine, if it's tablets, twice in a day, we tell them every 6 hours. If it is a medication that is given TDS, that is 8 hourly. We should be able to give by the clock. So it is 8 hours. Let the patient start their medication at 6 a.m., at 2 p.m., and then at 10 p.m. So we help them to count the hours so that the medication is given regularly. Then we have by the mouth. We prefer the oral route because sometimes having to inject a patient multiple times in a day is also inflicting pain. And we're looking at the simplest way of managing pain. Then by the ladder, that is the WHO ladder. We are going to look at it shortly. So the WHO ladder for adults has 3 steps. This ladder is good for managing cancer pain. If a patient has non-cancer pain or other acute pains, yes, the ladder is still applicable, but we do not want to give opioids for a prolonged period of time to patients without cancer pain or with a reversible cause of pain. So at step 1, we do non-opioid analgesics, which is paracetamol and NSAIDs. At step 2, we do weak opioids. In our setup, we have tramadol and dihydrocodeine. Then step 3, we do strong opioids. In our setup, the commonest is morphine. So adjuvants, there is plus or minus adjuvants at every step. Adjuvants are medications. Their primary role is not to manage pain, but when given with analgesics, they either potentiate the action of the analgesics or they work on a pain pathway, like anticonvulsants will work on different pain pathways. So we are going today to look at opioids because of time, we are not able to look at all these classes of analgesics, but it's good to know that basically we start with NSAIDs when the pain is mild, and then moderate to severe pain, we use opioids. Now that is the rationale for rating pain. Once we've assessed the pain and we've determined the degree of pain, then we choose the appropriate analgesic. Just because this is a ladder does not mean that we start at step 1, then 2, and then 3. So in the event that a patient has come with severe pain, we start with paracetamol before we get to morphine. We start at the point of the ladder that corresponds to the patient's pain. I believe we are going to look at pediatric pain management in due course. But something to note is that for children, we do not use weak opioids for cancer pain because research has shown that the metabolites of tramadol or DF118 accumulate in their system, and they tend to get more side effects than benefits from the weak opioids. So for children, we omit step 2 and we move from step 1 to step 3. Now, opioids are absolutely necessary, especially in palliative care. It is estimated that 80% of patients in sub-Saharan Africa, both children and adults, are still dying in a lot of pain. And therefore, opioids have been listed in the essential medicines from 1977 by WHO, for children also in 1977, and in the essential medicines for palliative care by the International Association for Hospice and Palliative Care. In Kenya, morphine is also listed as an essential drug, especially for palliative care. So opioids are natural substances that have been in use for ancient times, and they are either natural opiates or semi-synthetic alkaloids, and they are derived from this beautiful plant that is called opium poppy. So to make it simple, we classify opioids as weak or strong. And in our setup, the weak opioids we have is codeine, dihydrocodeine, and tramadol. Then the strong opioids we have is morphine, oxycodone, fentanyl, and methadone. But in Kenya, methadone is only used for rehabilitation for opioid addiction or for heroin addiction. We are not really using it as a painkiller. So we are going to really focus this discussion on the other opioids. So codeine, tramadol, and morphine. So these opioids, morphine is the prototype, and it's absorbed very well when it's taken orally. It is distributed to body tissues and it crosses the placental barrier. It's metabolized in the liver and excreted in the kidneys. So we have oral morphine solution, which is available in Kenya. It comes as a powder that is reconstituted to a syrup. This syrup has a half-life of 2 to 4 hours. Therefore, it means within 4 hours, within 2 hours, we have reached peak concentration, and within 4 hours, it's being eliminated from the system. Hence, the prescription we have is 4 hourly. The duration of action again is 4 hours. Then sustained release tablets have a half-life of 4 to 6 hours, and duration of action of 12 hours. We'll look at those formulations in a few slides. Now, opioids have receptors in the primary afferent and spinal cord transmission neurons, which is the ascending pathway, and then the neurons that are found in the midbrain and in the medulla, the descending pathway. So when you give opioids, whichever it is, tramadol, morphine, they go to the opioid receptor. So they will inhibit synaptic activity through activation of those opioid receptors or release of endogenous opioid peptides within the system. So when we give 2 opioids, for example, sometimes you'll get a patient who has tramadol and morphine on their prescription or their treatment sheet. Those opioids are going to act on the same receptor. Therefore, it is very hard to tell which opioid has sorted out the patient's pain. Therefore, we use one opioid at a time. We start with the simplest one, we maximize it, we go to the maximum dose. If it is not working, we move to the next opioid or a stronger opioid. So because these opioids work on the central nervous system, and we've said some of the opioid receptors are in the medulla. The medulla has the respiratory center. They cause sedation, they cause respiratory depression, nausea and vomiting, constipation, and euphoria. Euphoria is the reason why opioids are addictive, and that's why they are abused a lot, because they give people that feeling of extreme happiness. When we use opioids for a long time, like our patients in palliative care, they develop tolerance, dependence, and sometimes hyperalgesia. Hyperalgesia is a heightened sensation of pain, where some patients will even complain that a touch of a cloth will give them pain. But this is common in patients who have used opioids for a very long time. Now, in our Kenyan market, so it's African market, we have 2 types of morphine: the syrup or the immediate release morphine and the sustained release tablets. Now, the immediate release morphine comes as a syrup, and the preparations vary depending on the institution. The commonest one is 10 milligrams per 1 ml, but there are some institutions where you will find it is 10 milligrams per 5 ml. So please, when you're prescribing morphine, prescribe in milligrams, not in milliliters, because it depends on the formulation, and it's good to understand what formulation exists in your facility or in your vicinity. So the dosing is 1 milligram per kg per day for an adult. 1 milligram per kg per day, we then divide it into 6 doses. So 2/3 of that dose, a third of the dose is given at night, and then 2/3 is given in 4 doses every 4 hours. So I'll repeat that. We do 1 milligram per kg per day. For example, if someone is 60 kilograms, it means they need 60 milligrams of morphine. So this 60 milligrams, a third of that dose is going to be 20 milligrams. The 20 milligrams is given at night. Then the remaining 40 milligrams will be divided into 4 doses that will be given every 4 hours. Therefore, your patient ends up getting 5 doses of morphine in a day. So remember, we said by the clock, when we are telling them to take morphine every 4 hours, it is good to have the timing. Ask your patient what time they wake up. Is it 6 in the morning? Is it 8 in the morning? Then we start counting. From 6 a.m., 4 hours, the next dose is at 10 a.m. and we count up to the night dose, and we give them a medication chart to remind them of the time. Now, why I'm insisting on 1 milligram per kg per day, instead of saying let us start with 10 milligrams of morphine every 4 hours, some of our patients are very cachectic. Their weight might actually be less than 60 kilograms. If you give them 10 milligrams of morphine, it is going to be an overdose for them. So 10 milligrams, yes, is the starting dose for most adults, but it's good to also look at your patient. If a patient is very cachectic, we want to give them an accurate dosing of the morphine. Now, the tablet is a bit simpler. The sustained release tablet is given in 2 doses. So it is still 1 milligram per kg per day, and we give it in 2 doses. So morning and evening comes to 30 milligrams on average for most adults. Now, the challenge we have, the sustained release tablets are quite expensive. They are not affordable, and they are not easily accessible. Now, due to opioid restrictions, even in Kenya, we have laws of importing and Handling Opioids, we have a Dangerous Drug Act. So this morphine comes at a stipulated amount every year. So when we reach the maximum amount of kilograms or tablets that can be imported, then we have to wait for the next window for importation. So sometimes we have stockouts where our patients are going without morphine. The sustained release tablet goes for about 100 shillings. That's about $1 per tablet. Yet the syrup goes for about $5, which is about 500. And the syrup will last our patient for 1 month. And the tablets for 1 month is equivalent to a syrup supply of 6 months. So most of our patients are on the syrup because it is most affordable and it's more readily available than the tablets. So some of the side effects of considerations first before we go to side effects. When we are giving opioids to elderly patients, we have to lower the dose to 50% of the required dose. So for example, tramadol, we start at 50 milligrams. We can do every 3 hours for the immediate release. I mean, every 8 hours TDS. So for elderly patients, we want to do half the dose because their kidney and renal function is reducing. And elderly patients for opioids, we start at the age of 65, we give 50% of the dose. Where there is renal or hepatic impairment, we also want to adjust the dose accordingly. In pregnancy and lactation, we said that opioids cross the placenta and they cross the breast milk. Therefore, they are likely to sedate the neonate or the fetus. So we need to give them with caution. They are considered to be category D for pregnancy. They are not safe in pregnancy. We have to work with the gynecologist. When we need to give sedatives, morphine and tramadol and other opioids, they work on the medulla, receptors that are found in the brainstem, and they cause sedation. So when we need to give sedatives, it is good to consider which medication are we giving and how. So the question is, do you want to sedate the patient or do you want to manage their pain? If you want to manage their pain, you are better off increasing the dose of the opioids. If you want to sedate the patient, remove the opioid from the treatment and give them a sedative. Then when we need to use with anesthetics also, it is good to remember that anesthetics will also interfere with our respiratory centers. So it is good to consider which opioids are being used. So if we need to use sedatives or anesthetics together with opioids, we prefer to use short-acting opioids or opioids with a shorter half-life, shorter mechanism of action. Sorry, I think I omitted the slide on side effects, but we'll look at them as we go along. So there are some false beliefs about morphine and opioids, and I'll look at just 3 of them. The first one is that morphine should be withheld for the last days of life. So our patients with cancer, our patients who need palliative care, they are left to stay without opioids because people believe that morphine will hasten death, or we need to withhold until the last days. So morphine should be given for severe pain as soon as the pain appears or as soon as we assess that pain, and the dose can always be increased. Morphine hastens death. This myth has come up a lot because of the first one. When morphine is withheld until the last days of life, when patients are given morphine and they pass away, their relatives tend to believe that it's the morphine that caused the death. Palliative care, in fact, can prolong life when given alongside curative treatment, and morphine ensures that our patients have a good quality of life with relief from suffering. And even if they should die, they die a peaceful death. Then there is the last myth that morphine causes addiction. Now, there have been many studies that have been done on morphine, and it has been shown that morphine is not addictive. Now, addiction, of course, is not a problem that we'll undermine, and I will look at it briefly. But morphine itself, the way the molecule is not addictive. Therefore, we do not even have a maximum dose of morphine. We give the dose that the patient can tolerate and the dose that can relieve their pain. Tolerance is a biological, physiological phenomenon. It is normal. It means that someone's body becomes accustomed to a certain dose of morphine, and we need to increase the dose to obtain the same effect. And this occurs with prolonged opioid use. And in the case of morphine, any patient taking morphine for 14 days or more, that is 2 to 3 weeks, they end up developing tolerance. Addiction, on the other hand, or dependence, is psychological, where there's a strong desire to take a drug for the psychoactive properties rather than analgesic properties. And in opioid addiction, we find that patients who are addicted to opioids, be it morphine or any other opioids, they had a prescription for opioids for pain. The pain was controlled, but they continue to use the opioid even though they do not need the opioid anymore. Now, addiction in itself is a problem. When there's a criteria for addiction. When we identify that a patient is likely to have opioid addiction or opioid misuse disorder, instead of castigating them and denying them opioids, because these patients might still have pain and they tend to need a higher dose of opioids, we need to give them the necessary psychological and social support, because addiction, just like addiction to alcohol, is a problem. So I'm going to end there and invite any questions. Sorry if I have rushed through the information, it was quite a lot. And also we have a short time, but what we wanted you to get is just the overview of pain management in palliative care and especially opioids.
Great, thank you, Dr.
Thank you.
Esther.
Any questions? Yeah.
Yes, feel free to ask any questions. That was a great presentation and summary of opioids and pain management. There is one question in the chat box here. It says, what are some of the adjuvants used alongside morphine? And then another question just to follow up, what is an adjuvant drug?
All right, we can start with defining an adjuvant. So adjuvants are medications whose primary role is not to manage pain, but they work on pain pathways. So they work by either inhibiting neurotransmitters or potentiating the actions of opioids. So the commonest examples of medications that we use as adjuvants is steroids, like dexamethasone. Their role in pain management is not clearly understood, but they have an anti-inflammatory effect. Then we have anticonvulsants like pregabalin. Then we have pregabalin and carbamazepine are the common ones we use, and gabapentin. Then we also have antidepressants like amitriptyline and fluoxetine, and mostly we use them for neuropathic pain.
Great, thank you so much. I know you touched on this earlier in your presentation about methadone and why in the context it's used in your area. But there is a question from Susan who says, great presentation, why not use methadone for pain management?
Now, yeah, methadone is quite good for pain management because the ladder is NSAIDs, non-steroidal anti-inflammatory drugs. And Brufen is one of those non-steroidal anti-inflammatory drugs. So it is useful for step 1 of the pain management ladder.
Great, thank you so much. And so, and I am, Dr. Zippy says that there are very limited amounts of methadone in Kenya. Yes, we're talking more about opioids. I'm not sure if we do have a session later on in the course about adjuvants per se, but there are couple questions here. Can morphine be used both in adults and children?
Yes. Morphine can be used both for adults and children. So again, as I said, I hope that we are going to have a session on pediatric pain management. But yeah, morphine is used both for adults and children, and it can be used safely for both. Now, I'm going to share in the chat, there's a handbook by the African Palliative Care Association on beating pain. I'm going to share it with the participants so that they can also read more about pain management as we continue with the discussion.
Great, thank you. Yes, there are quite a few questions about adjuvants here in terms of we can get to those in a second, but I wanted just to focus on some of the opioid questions, seeing that that's our topic for today. The one question is, sorry, what is the effect of the opioid in pain management?
What is the effect? I don't understand the question.
Yeah, I'm not sure I do either. I wonder if it's, I'm not sure if they mean side effects or if what,
Okay. Maybe we could talk about the side effects. Some of the side effects include, yes, as we said, there's constipation, there is nausea and vomiting. Then there is respiratory distress, and there's sedation. Those are some of the commonest side effects that we see.
thank you. One question is about why is tramadol not used in children?
So yeah, research has shown that when we use weak opioids for a long time for chronic pain, that the efficacy is reduced in children because they are not able to metabolize the medication properly. So because their systems are still developing, they are not able to metabolize the weak opioids, therefore they are not able to get maximum benefits. They tend to accumulate the metabolites and therefore get more side effects rather than benefits from the medication. I've shared the book on the WhatsApp group, so you can download it from there.
Okay,
And, next question.
Is it possible to put it into the chat as well in case people don't have WhatsApp? Or
yeah, let me try. Yes, let me try.
Dr. Esther,
be able to.
Dr. Esther, I can try and download it while you answer.
All right.
Okay.
Yes.
So we have about 5 more minutes or so. So I think there are quite a few questions about the adjuvants. So if you're okay answering that, there's a couple questions on whether or not you can use pregabalin and fluoxetine together at the same time.
Yes, you can, because one is an antidepressant and the other one is an anticonvulsant, so they work differently. So when we are dealing with neuropathic pain, it's the one that is most problematic, and sometimes we need adjuvants, and sometimes we actually have to combine the antidepressants and anticonvulsants.
Yes, that's true. Sometimes you need different medications, and I guess it really depends on what you have available as well. The other question, I guess, again, on more about adjuvants and first step. What about diclofenac? I'm assuming that means, can that be used as well for pain management?
So diclofenac is an non-steroidal anti-inflammatory drug. Again, it comes at step 1 of the ladder. So for mild pain, we can use it if there is no contraindication. Now, NSAIDs also come with a lot of problems because they part of their side effects includes acidity, gastric ulcers, thrombocytopenia, that is platelet problems, and sometimes also there's kidney failure that is associated with chronic use of NSAIDs. So we really have to evaluate our patients properly before starting them on NSAIDs. And again, diclofenac, aceclofenac, brufen, they can be combined with the weak or strong opioids depending on the mechanism of action of the pain. I think we need more sessions on pain management.
Sounds like that. There's a lot of great questions everyone has here.
Questions. Yes.
Yes. Lots on adjuvants today for some reason. So the next question is, are steroids regarded as an adjuvant?
Yes. Yes, steroids are regarded as adjuvants because, again, their primary role is not to manage pain. They just have an anti-inflammatory effect which works for reducing pain. And they have many other benefits for patients on palliative care.
Yes, no, that's great. Thank you for all your questions. And there's a few comments in the chat box too, as well. So that's helpful. I think we might transition. Thank you so much, Dr. Esther, for the great presentation, and also just for answering a lot of great questions there. Just rapid fire, it sounds like. So thank you. I think we'll transition into the case discussion and case presentation. Sorry, and that's going to be presented by Dr. Kathryn, who is a palliative care consultant, and she's from the UK and also works with MSF. So I'll pass it along to you, Dr. Kathryn.
Can you hear me now?
Yes, we can hear you now. That's great. Thanks. And we
Great,
can see
thank
your
you.
screen as well.
That's great. Thank you, Anna. So, hello, everyone. For those that I don't know, my name is Kathryn, and as Anna said, I'm a palliative care specialist, currently working for Doctors Without Borders. And I thought we'd share a case from a recent trip that I saw on a recent trip to South Sudan. And actually, it's great that you have lots of questions about pain management. This case will focus on the management of pain, and we'll also have a time for discussion as well. And we can discuss some of the other questions you might have about pain management after this case as well. So I'm sharing here the case of a 35-year-old man who is currently an
Sorry,
inpatient.
Dr. Kathryn.
Yes.
Can everyone else hear Dr. Kathryn well? You're very quiet on my end.
Not clearly.
Yeah, of course, even me also. I'm not get you clearly. You should have to adjust maybe the value of your computer or your phone.
Okay, thanks.
Okay, thank you. Is that better now?
Yeah, that's better now.
Great, thank you. So I'm going to share the case of a 35-year-old man who's currently an inpatient, and he presented with this wound on his face, which is essentially a head and neck tumor that's presented late. And in the setting where he is, there's no access to oncological treatment. And he presented, as I said, with very advanced stage disease. And his main issue was severe pain, which was preventing him from sleep. So we did a pain history, and his pain is continuous, and it's over a large area of his face at the wound site. And he didn't manage to describe very well the pain, but he was able to tell us it was 9 out of 10 in severity. And the pain was keeping him awake at night. And his pain was worse at the time of dressing change, which he was having done on a daily basis. He had some relief with morphine tablets, and he was having immediate release morphine, 10 milligram tablet, as needed or at the time of dressing change. He was having 1 hour prior to dressing change, and this reduced the pain during dressing change a little bit, but he still had a high pain score even after the morphine. He said it was 7 out of 10. And he had other symptoms as well. So his appetite was reduced. He was quite low in mood and displayed this by being quite withdrawn. As I mentioned, his sleep was poor. And one of the main symptoms that the team reported to me was that there was a very strong smell from the wound. And actually the man, because of the smell, the man had been moved into the isolation unit in the TB ward, and the nurses were explaining to me that even then you could smell the smell from the wound was so strong you could smell it as you approach the TB ward. So it was a very, very strong smell, and there was a lot of bleeding at the time of dressing change. And the man was also experiencing quite a lot of itch at the wound site. So just to give you a very, very brief part of the social and spiritual history. So this man was married with 5 children. His father was the caregiver who was staying with him in the hospital. And his been as an inpatient for some weeks now, for some time, and he's actually very far from his home village. And they travelled around some areas of South Sudan looking for help with this problem he has. So he's far from his village, and he's a Christian, and faith is very important to him. So I just want you to think now about how we might be able to manage this man's pain. Okay, and I want you to think about Dr. Esther's lecture and the WHO ladder. So how might we manage this man's pain? And think about which medication might be most appropriate, medication or medications, and at which dose you might think about using them as well. And if you want to, you can type that in your chat, or you can put your hand up. And I can't see the chat function at the moment, so do let me know if there's any typing in the chat.
Sounds good. There's a hand up. Neonshima, I'll just ask you to unmute here. Go ahead.
Yes, good evening, everyone.
Hello there.
This man, since he is benefiting from morphine quick release, we can give him morphine as we are managing his pain. Then we follow the titers until his pain is managed with morphine. Then, meaning from there, we shall see the titers that will help him for his pain to be managed very well. Then another thing, he can be counseled because he looks depressed through counseling by experts in counseling and guidance. And the good thing is also a Christian, meaning we can follow holistic care and get some other people to.
Thank you. I lost you towards the end there. I don't know if it was everybody else as well, but what I heard was using morphine to manage this man's pain. That's very good. And also to get some counselling, mental health team support to support the gentleman as well.
Kathryn, there are a couple of hands up as well and a few answers in the chat. So there's using WHO ladder, 3 because he has severe pain. We can add an antidepressant for him, include NSAIDs, spiritual support are very important. And then there's a couple of people with their hands up.
That's great. Thank you, Anna. So do you want to call out one and ask them to unmute?
Sure. Bang Bol Reef, I'll just ask you to unmute.
Hello, Bang.
Yes. How are you? Are you getting me now?
Yes, we are.
Yes, we can hear you. Thank you.
Very good. Yeah, according to what you have been said before, the management of this man, because it seemed like there's a lot of sign and symptom, because it seemed like when the patient need the wound to be changed, it used to bleed. Also seeing how pores leave. Yeah, according to me, this one because before you rush to morphine or tramadol, because maybe, for example, the patient was brought to you today. So what you can do first, you can have to give paracetamol during the dreading time. So just you can observe for some minutes or some hours. Then if there is a resistance for paracetamol, you can go to tramadol. Then you can even also observe maybe for 4 hours or maybe 5 hours. Then you can proceed to morphine. So yeah, that is what I can do. And it can happen when I do the dressing, and even also when I witness that the patient not is living. So finally, as my colleague mentioned before, so you should have to call the counseling team and so that they can come and counseling the patient. Yet the patient need to be in a compatible area whereby he could be having full accessible for everything, like water. Someone can be close with him to have the conversation, yeah, so that reduce the stress or to reduce the emotion.
Sure, thank you, Bang, thank you. And there's some good points there. So having someone close with him to support him is really important. Having the mental health or spiritual support is part of his care. And if we focus on his pain, and it's not wrong to do step 1, step 2, step 3 of the analgesic ladder, but actually for this man, we know he was already taking some morphine and his pain was reducing just a little bit. So I wouldn't go back and start on step 1, okay? And I would actually say, okay, he's using morphine, just PRN, and he's still having pain, even the morphine is just bringing his pain down a little bit. So actually we need to stick with step 3. Okay, so I wouldn't go back to step 1 at this point. I would stick with step 3, but we need to give something regularly. Okay, so thank you. I'm going to move on. Thank you for your ideas and suggestions there. So what we actually did for this man is, as Esther recommended, and we used a starting dose of morphine regularly. And as Dr. Esther shared in her talk, that by the clock, by the mouth, by the ladder. Okay, so we use regular morphine because we know with managing pain, using it just when the pain builds up, we need much higher doses of medication to bring the pain down than if we give pain medication regularly and keep the pain under control. So for a patient who only has pain during dressing change, it will be okay to use it PRN and before dressings. But for this man who has continuous pain, we need regular morphine. So we gave him morphine, immediate release, 10 milligrams every 4 hours. And we did as Dr. Esther said, and actually we didn't wake him up at night to give him the medication. We gave him a double dose at bedtime. So it was 4 times the 10 milligrams and before bedtime 20 milligrams, so that he didn't need a dose in the middle of the night. Okay, and we used the same dose as PRN, so we used 10 milligrams PRN, and he could have this every hour if he needed to, although he never took it that often. And we gave it regularly 1 hour before dressing change as well. And as Dr. Esther mentioned, constipation is a very, very common side effect of opioids. It's almost all patients have constipation. And so we give laxatives at the same time as prescribing opioids. And this man already had some constipation before starting morphine. So we used a stimulant laxative, a bisacodyl, as well as lactulose, which is what we had available. And in fact, the only reason not to give laxatives is if you have a patient with diarrhea. Otherwise, you should prescribe them routinely alongside the morphine. And what we found is the man's pain reduced. It reduced down to around 6 out of 10, and he started to sleep better at night. However, his pain was still not controlled, and he was taking on average about 3 or 4 extra doses of morphine within 24 hours. So I just want to ask you now, what do you think is the next step for pain management? What should we do next to improve this man's pain? And do write it in the chat or put your hand up if you want to speak out.
So there is a hand up from before. I'm not sure if Mohammed Jelma wants to answer or ask a question. Did you want to unmute yourself? Okay. There's another hand that's up. Maybe I can ask Neon Shima to unmute.
Now at this step, we have seen that the pain of this man has reduced and the sleep has improved. And when you go back to the signs and symptoms he had, there was low mood and disturbed sleep. Then, meaning pain can somehow persist because of other factors like stress or depression. So this man, we can add some antidepressant as the counseling team is doing their work so that we ease the pain management. Thank you.
Thank you. That's a really good thought. So we could use an antidepressant if he has, because he had low mood, and that could also help with the pain with their analgesia, because we know in a wound like this, there's likely to be some neuropathic involvement, even if the man is not able to describe a neuropathic pain, which people often describe as burning, shooting, stabbing. So even without, we would expect there would be nerve involvement. So that's a really good suggestion. Okay, it's not actually what we did, but it's a really good suggestion, and it would have been a reasonable approach. I'll tell you why we didn't do that in a moment. So I'm going to move on. So what we did is we thought, well, this is actually a pain that's responding well to morphine. Okay, so we thought, let's increase, because 10 milligrams every 4 hours for a lot of people that's a good pain relief, and some people they need higher doses. And this man with that type of wound, actually it would be normal to need anyway higher doses, although you often only know by trying, right? So you always titrate according to pain and to any adverse effects of morphine. So for this man, we increased the immediate release morphine to 20 milligrams every 4 hours, and then we increased the PRN to the same. Okay, so 20 milligrams as needed, maximum every 1 hour, as well as 20 milligrams before dressing change. So what you'll see here is when we increase the regular 4-hourly dose, we also give the same dose PRN as well. And actually what we did do, again, we gave a double dose at bedtime so that he didn't wake up in the middle of the night needing an extra dose. And usually that just helps people to sleep better at night whilst using immediate release morphine. And with this, his pain was actually much better controlled. And we were lucky enough to have sustained release tablets available. And so what we did is we decided to switch him to sustained release so that we could try to get a sort of better therapeutic control, meaning every 4 hours he wasn't needing to take the medicine, and then the issue overnight where he's taking the double dose. And so while that works very well, if you have sustained release, it can be just a bit easy sometimes to just take twice a day. So we changed him to 60 milligrams every 12 hours. And just to explain you how we got to that dose, we added up the total oral morphine that he was taking in 24 hours. So that was 20 milligrams every 4 hours. So if you times 20 by 6, you get to 120 milligrams of morphine in 24 hours. And because sustained release is given as 12 hourly, we then divided that total morphine by 2 to get the dose of sustained release. So it was 60 milligrams every 12 hours of sustained release morphine. Okay, so this is the morphine that's lasting for 12 hours. And when we do the breakout groups, we can go over some of this again, because sometimes you need to hear it a few times for it to remember. So we gave him 60 milligrams every 12 hours of sustained release, but we keep the PRN to immediate release. So we continue with 20 milligrams as needed in case he had pain, and 20 milligrams before dressing change. And when we did this, he didn't take any more PRN medication. So his pain, and he told us that his pain was much better. And I just want to touch very briefly on the management of some of the other symptoms we mentioned earlier on. So for the itch, we actually added in antihistamine, and we used chlorpheniramine at night. And actually this really helped the itch, and it also, along with the morphine, it helped him with controlling the pain. It helped him sleep better at night. And he wasn't sedated in the day. We checked if he was feeling sleepy in the day, and he was not, and he was happy with that. So we were using the antihistamine for itch, but with the side effect that it would also help with sleep at night, as well as controlling pain. And his sleep improved with those measures, okay, with pain control, plus possibly a bit of the antihistamine. Now, we didn't start him on an antidepressant at this point, and that was because his mood was starting to improve as we controlled his pain. He was being seen by the mental health team. And at this point, I didn't want to add it. I would have gone for probably amitriptyline, which is an antidepressant, which is very good for neuropathic pain, and it can also help with sleep. So we give it in the evening time. It has a side effect of sedation, and also I didn't want to add it in at that time because he was already on. He was already improving with the pain control, and so we decided just to wait rather than adding a medication that could also cause more sedation. And so sometimes you want to do one or two things and just sit and watch how things are. But my plan for the team was, if needed, we add in amitriptyline. So, and here is a really nice tip. So for this wound, so when you have these fungating cancer wounds, malignant wounds, they can have a very, very sort of bad smell, and it comes from the anaerobic bacteria that are growing on the wound. And it's actually a toxin produced by the bacteria that causes this smell. So what you can do, rather than giving systemic antibiotics, you could just crush metronidazole tablets and apply them to the wound. Okay, and they usually work really well. So we were doing this each day with dressing changed. Within a few days, the wound was there was much less exudate, and the smell actually had gone within about 3 days. And the nurses on the ward had not done this before, and they were really impressed actually at how well the metronidazole can work for the smell for the cancer wound. So really good tip. You just take the tablets, you crush them finely, and sprinkle them over the wound. You can use 1 or 2 tablets depending on the size of the wound. I think we were using 2 for this man's wound. And for the bleeding, a dressing change, so we were soaking well the gauze dressing so this man had a gauze dressing and a bandage to cover the wound. Okay? So the wound was completely covered, and we were using we were soaking the gauze well so that when it was coming off, it wasn't not disturbing too much the tissue underneath. And we were using tranexamic acid ampules applied to the gauze and put over the bleeding sites, and this controlled the bleeding very quickly. Okay, so I'll just share with you some questions here, and perhaps we can keep this slide for the breakout rooms too. So I thought it would be quite good to discuss in small groups what we could do if this man's pain were to increase again. What might be the next steps to manage his pain? And can you think, and we've talked about it actually already a little bit in the discussion, but can you think of other pain management options that may be helpful for him? And let's have a think also about which possible medication side effects this man may have and how you might manage these as well. Okay, so that's 3 questions for discussion. And I think if you have any other questions about the case, let's take them now to the, unless there's any burning questions, put them in the chat or raise your hand now. Otherwise, we can take any other questions about pain management to the or any of the other issues we've discussed in the case to the breakout rooms. If you have any questions, particularly about this man's case, you can ask them now in the chat and I'll answer them. Otherwise, we can have discussion in breakout rooms.
Thanks, Dr. Kathryn. There were a couple of questions maybe we could just touch on before we go to the breakout rooms that came up. One is a ketamine infusion appropriate?
So we do sometimes use ketamine for very difficult to manage pain. And it's usually sort of 4th line if you want. We're going into sort of step 4 territory. So sometimes even with increasing doses of opioids, we can have very difficult to manage pain. And we do tend to go for medications like methadone or ketamine as a sort of, if you want, step 4 on the WHO analgesic ladder. Infusions, possibly, oral ketamine, possibly. The only thing to remember is it tends to be, and I've tended to use it in sort of bony pain. That's when I find it's more effective. And I don't know if any of the other faculty want to add any comments on
that. Okay, great, thanks. And then I think maybe one other question before we break out is, can we use tramadol and morphine at the same time?
Thank you for asking that question, because it's really good that we clarify that. So no, we don't use the step 2, so the weak opioids and the strong opioids together. So it's either step 2 or step 3. So when you can add in step 1, so we have paracetamol and ibuprofen or both together. If you feel that they're beneficial, and often in cancer pain, non-steroidals are very good. If you think they're beneficial, you can keep those and add in either step 2. And if step 2 is not good enough, you take out step 2 and add in step 3. So step 1 is the only one that you would keep alongside step 2 or step 3. Thank you for asking that question. It's good to clarify that.
Great. Thank you for a great presentation of this case and for answering the questions. There's a lot of questions in the chat as well, so maybe we can take those to our groups. So I think what we'll do now is go into the discussion in the breakout rooms, and I think that will somehow happen for us.
Yeah, I'll start them now. So we'll have 6 groups, and the faculty that are on the call today, you'll be leading the discussions. And I've included the 3 questions that we can talk about, and of course you're free to discuss other issues. If you have any problems, there is a help button, I think, or something like that in the breakout rooms. If you need any help, just let me know, and I'm in the main session. So I'll open the rooms now, and we'll have about 20 to 25 minutes until we end the call. And I'll bring you all back into the main session when we're done. Thanks, everyone. Hey, Paul. I'm not sure if you wanted to go to a breakout room. I can send you somewhere.
Great. I think we're just waiting for everyone to get back to the main room here. Are we, looks like we should all be back now, I think. So welcome back, everyone. I hope you had a good discussion with your small groups and had good questions that came up in your groups. I think I don't know if there's any other questions that just looking at the box here, chat box, to see if there's anything else that has come up. I think the slides are made available. And our next session will be on symptom management by Dr. Maha and Vicky Opia on June 14th. So next Tuesday at 4 p.m. East African time. I don't know if there's any other announcements, Erin, that you wanted to make, but I think everyone had some good.
Yeah, I think we're okay. I did just see if Dr. Esther or you, Dr. Anna, or Dr. Kathryn wanted to, there was one question about breakthrough pain. I don't know if you wanted to review what is breakthrough pain. Just before you guys went into in your breakout rooms, someone asked about breakthrough pain.
So
Dr. Esther?
breakthrough pain, breakthrough pain is generally happens in a background of controlled pain. Sorry, let me just, please mute your microphones. So breakthrough pain happens in a background of controlled pain. When we have a patient with controlled pain, then in between the doses of their medications, they get an episode of pain. So it can happen towards the end of dose of medication, or it can happen because of like the case that was presented, procedures like wound dressing. And sometimes it can happen because the dose of the medication is inadequate. So the patient starts to get pain way before the next dose. So it's problematic if we get more than 3 episodes in 24 hours, then we need to adjust the dose of medication or to switch to stronger medication. I think that's the simplest way I can put it. Erin, would you like to add to that?
Yeah, I think what we do need to do is teach our patients and families about pain. And as you learn more about pain, you'll be better equipped to teach your patients and your families, because sometimes the way a patient experiences pain is different and they may need extra doses. So as you feel more confident in learning about pain and managing pain, then you'll be better able to teach your patients. So I think what today taught us as faculty as well is that there is a lot of questions about pain, and that yeah, we are here. Dr. All of the faculty members have committed to being part of this course for the full course. So don't hesitate to reach out to us. If you have a very specific question about a single patient, or if it's just a general question so that you're more knowledgeable, we are here to support you. So specifically for breakthrough pain, we tend to find it, like Dr. Esther was saying, on patients that are already managing their pain with a pain regimen. And then what tends to happen is the pain is even too severe for that, as Dr. Kathryn is explaining in the case presentation. So, but we do have ways to treat that type of pain with immediate release medications. I am quite interested to hear what you have access to in your settings. From what we have heard in the past from IRC, at least in Kenya, in the settings, it's very difficult for them to access things like morphine and opioids. So I think maybe we can move that discussion on to our WhatsApp chat and just talk about what you have access to, because that can also help people like Dr. Esther and Dr. Kathryn and Dr. Anna to advise us on what to prescribe in the field. So maybe that's a discussion for our online WhatsApp group. I'm just going to add the link if you aren't on our group yet. I'll just add the link into the Zoom. But otherwise, thank you so much. Thank you, Dr. Anna. You're a great facilitator, and Dr. Kathryn for your case, and Dr. Esther for the lecture. Thank you so much, everyone. And hopefully we'll see
Thanks,
you
everyone.
next week.
Bye.
Thank you, El. Thank you, Dr. Anna, Dr. Esther,
Thank you.
Erin.
Thank you. Thank you.
Thank you. Thank you.
Okay, Dr.
Thank you for all the
Bye.
wonderful presentations.
Thank you. Bye.
Bye. Have a
Thank
great day.
you. Thank you. Bye. Bye.
Yes, thank you.
Welcome.
Thank you.
Bye.
Bye.
Welcome.
Bye.
Welcome.
Bye. Thank you.
Bye.
Bye. Bye.
Bye.
Thank you.
Thank you.
Thanks, everyone.
Bye-bye. Bye.
Thank you. Bye.
Yes, yeah,
Thank you. Thank you. Thank you. Thank you.